Gijs, I understand that you've been with AKDN and the health services now for maybe close to 20 years. But before we get into that, can you tell me a bit about your journey to the Aga Khan Health Services?
That's an interesting one, Alia. My background, I'm a medic. I'm what you could call a Dutch tropical doctor, which is a unique thing. Okay. So after you finish your training as a medical doctor, you do additional training and residencies in surgery, obstetrics, gynecology, pediatrics, so clinical topics, as well as a course in tropical medicine. And I had been as an intern to Tanzania many years ago. And that led to me to want to work in a low-income setting, and specifically to serve a population at that level, at the district hospital level. So that's what I started doing, and you're talking about, like I say, many years back, the end 1980s. And I started working in a district hospital in northwest Tanzania. And I knew a bit about Aga Khan Health Services. There was a health center in Mwanza, and obviously there was the hospital in Dar es Salaam. Much too early, after 1 year, I became the in charge of that hospital. So I needed to take on additional management responsibilities. I also quite quickly realized that doing clinical services and trying to make a difference with individual patients was satisfactory, but there were major problems in the community. And that led me to start thinking about levels of maternal mortality. Many women would come in to the hospital late and would die, for instance, within the first hour after coming into the hospital. And we didn't know very well at that time what the levels of maternal mortality were in that particular setting. So that led to my PhD. So I did my research at that time on measuring levels of maternal mortality in the community as well as at the hospital level, and come up with a number of interventions to reduce maternal mortality. That led to my next job. So after having worked for 7 years, and really the combination of clinical work, community health, public health, management and implementation research, or not only research, I was asked to go and work for the British Medical Research Council in the Gambia in West Africa. And that's what I did for another 7 years. And it was again, I led a research unit, and the UK MRC has its largest overseas unit in the Gambia. It's quite well known for its work on specifically infectious diseases. Originally it was malaria, meningitis, a number of infectious diseases. But also what I did there was paying a lot of attention to research and interventions in relation to maternal reproductive health as well as non-communicable diseases. But I think it was that combination of having expertise on different disciplines which are all relevant to the overall portfolio of health, so clinical, management, research, led to, and I still remember it very well, it was in 2003 that I got a phone call from a headhunter which asked me whether I would be interested to join AKDN and start working on health within the AKDN. And it made sense on the personal level at that moment in time for us as a family to move back to Europe. So, and that's how it ended up that I became part of AKDN.
Amazing. So I must ask, on behalf of my 5-year-old at home, who will want to know who I've met today, how can I describe to her what you do and what Aga Khan Health Services does?
What I try to do is to improve the health of populations and populations who need it most. And I don't pretend that I am doing this, because indeed the vehicle which helps me doing that is the Aga Khan Health Services. And the Aga Khan Health Services works to improve health of populations, the Jamaat and its neighbors, and does that through health promotion, disease prevention, which is something which doesn't get attention enough often, but also then health service delivery. But health service delivery which ensures that people have access to healthcare at the right level, which is accessible, affordable, and makes sense for that particular family, individual family and the population.
Pretty powerful. And there's a lot in there. And if I think about the journey of health services, you know, over the last, I guess, few decades, it's been an important part of the work of the Ismailia Mamet and its institutions for a long period. Can you give us an overview of the journey that it's gone on, or the evolution from the time of Sir Sultan Mahmud Shah right to today?
So then we go back a long time. It's in fact not a few decades indeed. In 1924, the Karadar, what is now the Karadar Hospital in Karachi, was opened and started its first services. And it was a maternity home. And you see that quite often over time. Indeed, many of the older ones, and you talk about Mombasa 1944, if I'm correct, I think it was, the next one was Kisumu in fact. And then you have in the 1950s and the 1960s a number of these units opening. And they really started as dispensaries or maternity homes, and they evolved organically over time. And that was had happened until, let's say, the 1980s. In the 1980s, you started seeing a much more sort of comprehensive approach, really looking at the community and starting to look at the community as the base, and then building the health system according to the needs of that particular community. So it would be community health workers, it would be primary or basic health centers, then the next level would be what you could call comprehensive health centers, and then you go to the district or the provincial hospital. You see at that time, from the 1980s onwards, also coming in closer alignment of what we should be doing in that particular context and what the governments were doing. So we would work harder and do much more to ensure that what we were doing, obviously it's on the invitation of that particular government, but also ensure that there is complementarity. And that played a very important role from then onwards. The growth of what Aga Khan Health Services is doing continues until today. Was it initially a lot of primary health care focusing on the burden of disease at that moment in time, so talk about maternal health, child health, infectious diseases, and a lot of emphasis on primary care. Over time you see that evolving. So you see secondary health care coming in. You see even in some circumstances also in the rural populations, or serving the rural populations, the tertiary healthcare services coming in. At the same time, and you're talking about, in fact, the Aga Khan University Hospital in Karachi was established in 1985. So you see the whole continuum of care, or what you could call the hub and spokes model with the apex institutions of tertiary and teaching hospital, with a lot of attention to training and research coming in at that time as well. And again, it continues until today. So recent developments, if it comes to the involvement of the health units, you see now good quality secondary hospitals also coming in place, let's say in Gilgit or in Booni, in Karok. So really those kind of geographies are getting more and more advanced care as the situation evolves. And also the expansion geographically. We are now establishing the first health center in Salamiyya in Syria, for instance. And not that we're forgetting about the more mature countries. Very exciting is, and I was there not so long ago. In the 19th century, the old dispensary in Zanzibar was constructed by Mr. Topan, and he was a wealthy Ismaili merchant. That particular building was improved and renovated by the Aga Khan Trust for Culture in the 1990s, and we are now taking it back to its old purpose, and it's becoming a health center.
Fantastic, that's exciting. I look forward to hearing more about that. Gijs, just to go back to something you mentioned, the hub and spoke model, can you explain that concept a bit more, just to help me understand that?
The hub and spokes model is about ensuring that people have access to healthcare as close to their home as possible, but also ensuring that you have the right use of limited resources. So when you have a common cold, you don't have to go to the hospital. But it still happens too often that people go to the hospital for a common cold. So it really tries to pay a lot of attention in the community via our community healthcare workers about health promotion, disease prevention, so limited curative care at the community level, but if you need something else, that you're being referred within that system and that you access the level of the healthcare according to that particular problem.
Got it, that's helpful, thank you. And just to situate healthcare kind of more broadly, the mandate of the AKDN is to improve the quality of life, and Hajimam talks a lot about eradicating poverty. From your perspective, why is access to healthcare or quality healthcare critical to eradicating poverty?
It's both ways. So poverty leads to poor health, and that is well known. It's well known at the global level. It's well known if you compare low-income countries via middle versus high-income countries, but also if you look at poverty within countries. You might know that if you take London, for instance, and you're from the UK.
I know it well.
So the further you go away outside London on the metro line, the life expectancy decreases. And it is related to, that, like I say, it's two ways. On the one hand, poverty leads to poor health, but poor health also leads to poverty. If you're ill and you don't have a stable income, how are you going to access healthcare, and how are you going to pay for your healthcare? It's a real issue, and you see it as well that people who can't afford much, if they have to pay for high healthcare costs, it leads to what is called catastrophic health expenditure, and really it could put people and families into further poverty. But we also know that on the journey, that if you have a poor start, so you are poor, you're born as poor, your nutrition might not be so good, you might be more ill as a small child. That leads also to issues later in life if it comes to, even if you go to school. If you go to school, you might have more absenteeism if you don't have the proper food or the proper vaccinations. Again, it leads to more disease. It leads then possibly to poor health. And if you then go further on, if you're an adult and you have gone through that trajectory of poverty and poor health, again, that leads then often to, let's say, less income, etc., etc. So it's really both ways. And obviously it's not only health, it's also education. If you are better educated, it's easier for you to find ways to get proper access to health services. If you're poor and don't have the contacts, don't have the contacts, it is more difficult.
Yeah, that makes a lot of sense, that that relationship. And looking then at that in the context of the health services within the network, how does AKHS relate to or work with some of the other agencies within the network?
We have several linkages to other agencies, including, for instance, Jubilee. So we have a particular, what we call micro health insurance product with Jubilee in northern Pakistan. We're developing at the moment one in Tajikistan. Similarly, in East Africa, we have some of those products. Also, when it comes to, it's a combination of factors. In fact, in the case of Tajikistan, we're making use of a combination of entities. In Gorno-Badakhshan, you have Pamir Energy. Pamir Energy provides energy. And they have what they call debt collectors. They have people who come on a regular basis, go out and collect the fees for the electricity provided. We're using those people, as well as from the Mountainous Society program, people who advocate for taking on the products which can ensure access to the Kourok Medical Center, the Aga Khan Medical Center in Kourok. That is also being stimulated with a card which is being stimulated and promoted by the first microfinance bank. And in addition to that, in Tajikistan, we're making use of T-Cell. So the mobile phone company is helping us with the messaging around it and also making it available, certainly in the future, of mobile banking and the telephone. So all of that we can bring together, and we're trying to do that very hard.
Pretty powerful. You've got all these different components coming together. It must be quite, it must be quite inspiring to see all the pieces of the jigsaw kind of fitting together. It's impressive. Thank you for...
And really that's something which makes AKDN unique, the ability to do that. And we need to do much more, let's be clear about it. But there's a lot to do in that regard. But I think bringing the different assets of the AKDN together is an extremely powerful tool we have. And it goes beyond ensuring that people have financial access to health services. It's in general about access. The use of the Nation Media Group in East Africa is another example where quite often our health experts are being interviewed on radio, television, or write an article to again do things which are important in relation to health promotion and disease prevention.
That's amazing, thank you. I'd like to just ask a little bit about the principles for Aga Khan Health Services. So you've got obviously the different levels of provision across a number of geographies. What are the principles, or what is the thinking that kind of combines all of those different service arms?
So when it comes to the principles, there are a number of principles. It's about access, it's about quality of care, and we probably should discuss that a bit further, because quality of care is extremely important also to His Highness. That's something he continues to emphasize again and again. So access, quality, affordability, being a role model. We can't provide healthcare everywhere. We do it where the Jamaat is present, and we provide that healthcare then to that particular population. So it's the Jamaat and its neighbors. But we really hope by measuring that and document that well, that others learn from us, and obviously not only learn from us, we can also learn from them. But in general, we really try to be a role model and hope that others start replicating some of the things we are doing.
Can you give me an example of that role modeling?
Yes, I can certainly give you a few examples of fact, but we try to strive for accreditation. So the university hospitals, Aga Khan University Hospital in Karachi, Aga Khan University Hospital in Nairobi, are what is called Joint Commission International Accredited. It's the gold standard, the highest standard in high income countries of accreditation of standards of care to ensure safe quality care. We're also doing that now also in some of the Aga Khan Health Services hospitals, including, for instance, the one in Dar es Salaam. And it's not only about our own health facilities. The learning has been so far that governments are very interested in that. Other non-for-profit and for-profit providers are interested in this. And it's becoming sort of a standard of trying to do things better if it comes to quality care provision. And a number of our own people who work in our own hospitals and are heavily involved in ensuring this quality of care and the measurement of it, we make them available to others as well, to influence that and to ensure that others as well get to that kind of level of healthcare provision.
It's interesting you talk about quality care. In 2011, Hazrat Imam said,
"Let the day also pass when African patients think they must go to other parts of the world to find quality medical care."
What are your thoughts on this quote?
It's a fantastic quote. And that again, it goes back to what I just mentioned to you. And I think it has been His Highness's philosophy. Why would you have substandard care in anything, not only health, but certainly in health as well, in low and middle income countries or compared to high income countries? And that's not to say that everything which is good in the high income countries should be replicated blindless. You really need to look at what makes sense in that particular environment. In fact, many things we are doing in our own settings, I think the so-called developed world or the high-income countries could learn from.
You make a very, very fair point. Just touching on something you mentioned earlier in your career history, actually, that you worked in non-communicable diseases. What's driven that change within the health services or within that vision around moving from communicable diseases to non-communicable diseases?
It's not that we are forgetting about communicable diseases or maternal and child health. It's still very important to us. However, the burden of disease is changing, and you see non-communicable diseases coming in a major way, also in low and middle income countries, and there's a clear relationship why that is. When it comes to some of the things which have happened, and I'll give you the example of Gilgit-Baltistan. Gilgit-Baltistan, we started with this comprehensive primary health care, and then over time it started evolving in the 1980s. And we have relatively good baseline data of the health status of that population of the mid-1980s. And we have seen a dramatic reduction in maternal and child mortality. In fact, at the time in the 1980s, the indicators were worse for Gilgit-Baltistan than the rest of Pakistan. And that you can understand that it's a relatively isolated, high mountainous area with all sorts of challenges compared to other areas in Pakistan. If you now look at the current status, the health indicators of that particular population are much better than the national figures. And one of the things which has happened is that the life expectancy in the mid-1980s was 54 years. Now it's 69. So obviously then also with the change in the demographics, change in lifestyle, you see other diseases coming in. And we pay a lot of attention now to dealing also with, let's say, hypertension, diabetes, also mental health issues. And all of those things need due attention, obviously. And we are adapting and evolving our health system as we need to do to serve the populations better.
When we think about adapting the health system to serve the populations, I like that thinking, and what comes to mind is there's a lot of focus at the moment around gender equity, gender inclusion. You've talked about maternal health already, and children's health. What is the health services doing to promote gender equity in the areas you work?
Of course, we can do better, but the majority of our patients are women, partly because we are so strong in maternity service. The majority of our employees are women, but also in management, and of course we can do better, like I said already. But 4 of our 9 CEOs are female. Okay. So I think we are doing pretty well. And in fact, if we are sometimes accused, related to that, of the fact that we still don't do perhaps enough if it comes to paying attention to non-communicable diseases and the elderly, that perhaps we don't do enough for the men.
Just a question around the collaboration between the health services and I guess other stakeholders in the contexts you work, so the governments or the civil society institutions, other healthcare organisations. How does that relationship develop? How does it work in different places?
It's very different in different places because each country and each context is different. But I want to take one step backwards. And we talked earlier about how other AKDN agencies can help, in this case the health services, in relation to ensuring access to healthcare and financial. AKDN, like I said, is unique. When it comes to health and healthcare, our main partners are the Aga Khan University and the Aga Khan Foundation. And you see increasingly a close collaboration between the Aga Khan University and the Aga Khan Health Services, as we are complementary and we can learn a lot from each other. And that pathway of close collaboration is going to evolve further as we go forward. And that will help both entities. Together we are stronger than as individual entities, as always. I mentioned to you the enormous improvement of health indicators in northern Pakistan. And we also have good data, in fact, for instance, northern Afghanistan, Afghan Badakhshan, where you see a very good improvement in indicators related to maternal and child health in that particular population. But I think we should not overdo the impact of health and healthcare. Obviously we make a bit of a difference, but it's also about safe water, adequate sanitation, proper housing, etc. And the uniqueness of AKDN is that it brings it all together. And that is, I think, yeah, it's absolutely amazing and unique that you can do and bring all these entities together for one goal, which is improving the quality of life of the Jamaat and its neighbors. But then to come to the point of how do you work in each country? And each country is different. So initially, a lot of the health services were our own assets. We own, and it's still the case in the mature countries, to put it like that, East Africa, India, Pakistan, where AKHS in this case owns and manages health facilities. Increasingly we're working now on public-private partnerships. And for instance, to give the example in Afghanistan, and of course Afghanistan at this moment in time is very unique and not an easy situation. But even today we manage the provincial health systems of Badakhshan and Bamiyan on behalf of the government and the total health system. But we were able to continue providing those health services even in August 2019 and continue to provide those health services despite all the turmoil and the change. And we were unique. We were the only two provinces, as far as we know, in the country where the health services continued uninterruptedly. Situation is different from each country, and things are different in each country. In Tanzania, a number of years ago, when we started engaging around this, both with government as well as the French Development Agency, there were no modern radiotherapy equipment, not one in the whole country of 45 million people. We're bringing now in what is called Linkages, which is the most modern way of providing radiotherapy with least side effects, as well as really establishing systems around proper diagnosis, early on proper diagnosis and treatment when it comes to chemotherapy, surgery, radiotherapy. And we're not doing that only at the Aga Khan Hospital in Dar es Salaam. We're closely collaborating with the public national cancer hospital in Dar es Salaam, which is not that far in distance from the Aga Khan Hospital in Dar es Salaam, but also doing it up country in a place called Manza.
And just forgive my ignorance, this kind of service is available to the wider population on a private basis, or, you know, I mean, is it how does it work?
Sure. Again, it varies from country to country. Yeah. In a number of situations, Aga Khan Health Services works private, not for profit, so it has to recover its costs. Yeah. And His Highness has always been very gracious and has been very clear about it needs to be seen within the context of the affordability of that particular situation. To give you an example, the Aga Khan Medical Center in Kurok, which was established in 2017, we presented that plan for establishing that facility. So there was a major capital investment, but we also presented the fact that initially the population would not be able to afford that health center and the services in that health center, so it would need to be subsidized. And we presented a plan to him that over a period of 10 years, that contribution from the imamat towards the health service delivery would decrease, and hopefully over time the affordability and the uptake of the population would become better. And His Highness is very, very not only understanding, he drives that in a way. That it needs to be seen within that particular context of what you can and what you cannot do. There are a number of circumstances, and that brings me back to Afghanistan. In Afghanistan, we provide those provincial health systems services on behalf of government, but in this case, because of the poverty of those populations, with, in this case, donor funding, which come through and are coordinated by the World Bank. And there are then major donors on the background of this, for instance, USAID, the European Commission, Global Affairs Canada, etc. Okay. So again, each context, each country, different. And we need, in that regard, we need to be very flexible.
Absolutely. It's very complicated, but also, I guess, with the beneficiary in mind, right? With the patients or what their sort of situation is.
Yeah, and it goes back to the principles. That's the principle about access, quality, affordability, role model. Yeah. All of those things come back.
So tackling the effects of climate change is quite high on the agenda for a number of the AKDN agencies. And I understand that the footprint of healthcare, when we're talking about the environment, is quite significant. Is the health services doing anything in this regard?
Climate change is important for all AKDN agencies, including the health services. And when it comes to health and health services, you might be surprised. I was also surprised to get to know that 4.1% of the global emissions related to the carbon output is related to the health industry. So it's extremely high. And we have been tackling this in a major way, I would suggest. We started by doing an assessment of what were our carbon emissions and have developed a tool for that, which was not available, certainly not for low and middle income countries. And we have done this now in a number of our countries in which we work and with our own institutions. And that has evolved, and that tool is now being used by the World Health Organization, by the International Hospital Federation, and a number of entities. So we really, you could say we're leading the way. And leading the way not only in the assessment, but now also taking the actions. So we have developed for our countries plans for the coming 5 years of how they can reduce their carbon emissions and become green in a way, or more green, with the aim that we would become net zero before 2030. And the good news is that in the coming 5 years with our plans, we can reduce our emissions already with 60% compared to what it is today. And there are a number of interventions, the usual ones related to our buildings, if it comes to solarization, other usage of doing away as much as possible with the carbon fuels there, making our buildings more energy efficient, doing away with the use of single plastics as much as possible. And in healthcare we use a lot, but also very specific things in relation to healthcare. Inhalers, the inhalers which you use for asthma or other diseases, is a very important one if it comes to emissions. The use of anesthetic gases. There are some gases which are much more polluting than others. So we're really adapting which gases to use and also moving away from gases and giving anesthesia in different ways. For instance, regional or spinal or epidural anesthesia much more where we can. We are adapting as much as possible and advising, and it's good for health anyway, if it comes to diets and the usage of the food in our hospitals, both for patients and staff. The biggest consumer in relation to health and the biggest polluter in a way is what we purchase. So our pharmaceuticals, our equipment, etc., etc. And we're really trying to push, as we have some power, because what we do as a system, bringing together the Aga Khan University Health Service Delivery as well as the Aga Khan Health Services, we have what is called group purchasing. So we purchase in bulk, for instance, certain medicines, etc. And we're really pushing the manufacturers to establish their standards as well. And we want and are increasingly demanding from them that they share with us their zero net plans as well, and will purchase increasingly in agreement to those who produce and manufacture in a green manner, to put it like that.
It's quite pioneering to hear you talk about emissions being a consideration alongside what's best for the patient when choosing the kind of the approach to take.
And if it comes to climate change, health professionals are often regarded as examples within society. So it has really been taken on board by many of our staff in a major way, and they have become major advocates. In fact, it has somehow surprised me how engaged they are, even if they have many other challenges to deal with. But they really feel passionate about it and understand the size of the problem and that we need to do something urgently.
Fantastic. Can I now fast forward maybe 20 years, 30 years to the future? What does the Aga Khan Health Services look like?
You should ask His Highness, I guess. No, healthcare will look differently. And we might have the advantage working in low and middle income countries that we don't have vast health systems in place, and that we already have been building on the community and starting with the community as a base, paying a lot of attention to health promotion, disease prevention, making healthcare available close to homes. And another part of that is we have a very important initiative in relation to digital health. We have what is called the AKDN Digital Health Resource Center. It's based in Karachi, but we're doing a lot of diagnosis and treatment and supporting in the rural areas, for instance, community health workers or community-based healthcare workers, with expertise which is available in tertiary institutions like the Aga Khan University Hospital in Karachi. Right. So we do a lot of digital health, what we call digital health, so teleconsultation, tele-diagnosis, tele-ICU, tele-surgery is coming in, where we're really trying to help each other as a global community and trying to bring that treatment, make that available even in isolated areas, but without people having to travel. Healthcare overall is going to change. I think a major experience around and finding around COVID-19, probably the most successful vaccines were the ones which were based on mRNA. And mRNA is going to make, and it's only one example, there are other examples as well if it comes to treatments, but it's going to evolve. And the way how we treat will become more precise and much better. And something which is called personalized medicine is going to come in. You will probably have hospitals, if it comes to hospitals and inpatient care, at the global level you will probably have lost hospital beds, but they will be for more acute care. You will have within a hospital more beds which are for intensive care, high dependency care, and less general beds, for instance. So it's about the acuity as well. You see that evolving. But you see a lot of treatment now already happening, and it will increase to take place closer to the patients, including diagnosis and treatment, and as much as possible one stop. When it comes to the healthcare professionals, we're facing a problem, and a major issue for us in the situations which we work in is that many of our healthcare professionals are being poached. They're being poached by the high-income countries, and in fact it has increased since COVID-19 ended. And so when it comes to healthcare professionals, there will be a shortage, and we need to see how we get more people interested to become a health professional, and we will continue to have to play an important role as AKDN in training people and preparing them for the future. The education of health professionals will be changing as well. It will adapt to that particular situation and that context as needed. But there's lots to be done, and certainly it will look different in 20 years.
Excellent, excellent. Thank you. Thank you for explaining that. So you'll be aware Hazrat Imam celebrating 65 years of his imamate this year. From your perspective, looking at the 65 years and your almost 20 years in health services, what's his legacy for this period?
Obviously it's tremendous, and when it comes to health and healthcare, in 1978, so a very long time ago, there was what was called the Alma-Ata Declaration. And the Alma-Ata Declaration established at that time the idea of health for all by the year 2000. And that goes back to the thinking around comprehensive primary health care. So about universal health coverage, access, intersectoral collaboration, the wise use of resources within that context, and the influence and community participation and civil society. And that was done at a global level. In November 1981, the person who was responsible for that Alma-Ata Declaration was the Director General of the World Health Organization at that time, Haftar Mahler. And he came with His Highness to Pakistan in 1981, and exactly that was the main topic of conversation. primary healthcare and hospitals. His Highness already at that time as well saw the importance of the continuum of care, of the hub and spokes model, the importance of education and research, and really making available this total health system based on very good principles to make it available everywhere. And I think we're still building on that legacy, even today.
Mm-hmm. Yeah, I'm sure then you clearly are. You've got a lot of things going on to build on that. And in your role, you've had the opportunity, or the opportunity, I guess is the word, to interact directly with Hazra Imam and members of his family. And I'm just wondering if there's any stories or moments that you'd be happy to share.
A few. One of the things which was early on in my tenure, we were talking about short-term, medium-term and long-term. And I was talking about, let's say, 1 or 2 years short-term, 3 to 5 years medium-term, and beyond that long-term. His Highness said to me, medium-term is 25 years. Can you imagine? That's the kind of mindset and the thinking he is having to move things forward and ahead. He doesn't think about, of course he thinks about today as well, but it's that sort of really long-term perspective, which we often don't have. Mm-hmm. The second thing is being with him during field visits. He does very unusual things. We would be taking him on a tour, let's say, to show him the most recent new equipment and operating theatre. He would go off to the kitchen, or he would go to the roof of the building and look around and say, what is happening there and there and there. And to me, that's a major takeaway as well. Then one other thing I want to, and I'm going to read a bit about this. It was in November 2005. I was still in Egelmont, I wasn't in Geneva yet. And Prince Rahim, His Highness and Prince Rahim, came into my office, which is something which doesn't happen every day. So
Quick, tidy your desk.
He came into the office and he was extremely happy and pleased, because at that time I was also had responsibility also for the Aga Khan Planning and Building Services, and he had just heard that we had received the Al Khan Prize, and His Highness gets many prizes and awards and recognition, but he was very, very pleased, and I understood later why that was. And it was, I think, because it wasn't for a specific project, or it wasn't even a lifetime achievement. Really, and I'm now reading off the sort of what the jury came up with. It was for the Aga Khan Planning and Building Service in Pakistan. And they wrote at that time, and later expressed it, Prince Hazara received the prize in March 2006 in Vancouver. It is about clarity of conception, effectiveness of implementation, and the quality of results in the present, over a period of time, and with its focus on sustainability into the future. It is about developing and using world-class knowledge and working with local communities to choose and implement what reflects their needs and ability to sustain. The key dimensions are the interventions must be grounded in communities, must integrate social, economic and environmental elements, and be undertaken with a long-term perspective. To me, that summarizes a lot of what His Highness has achieved over the 65 years. It's extremely good summarization, not of this particular work of Aga Khan Planning and Building Service in Pakistan, but I think overall.
Amazing. I think on that note, I'm going to say thank you so much for this conversation. It's been enjoyable and I've learned a lot, so thank you really.
Thank you, it was a pleasure.